Week 2015. In case you didn't know, you're in Las Vegas. And so at this point, how many of you are winners? How many of you are losers? And what made you think I was asking about gambling? You don't have a very high opinion of yourselves. Now, come on. I want to point out to you that you are attending the 9th consecutive PAINWeek conference. And I am your MC tonight. My name is Dr. Michael Clark. I'm from Johns Hopkins University School of Medicine, and I represent the American Society of Pain Educators as well. And on behalf of my faculty colleagues and all of us who work to bring this conference to fruition, I'm pleased to welcome you here. I want to point out also that this is another record-breaking year, right? And the reason why it's record-breaking is that for the 9th consecutive year, we have broken attendance records. We now have over 2,200 attendees. We are the largest pain meeting in the country. And that is because of all of you, all the people that make this conference happen, and everybody deserves a round of applause for that accomplishment. So with 2 days of Pain Week already behind us, you've had the opportunity to sample the diversity of offerings of a 150-hour curriculum. That is no small feat either. But there's much more to come and much that is new at PAINWeek 2015. Great strides have been reported during the past year in our understanding of many topics such as migraine. And the American Headache Society is with us to present their full-day comprehensive migraine education program. The American Pain Society returns to PAINWeek on Friday with an all-new program that is devoted to the management of chronic pain in older adults. On Saturday, the American Society of Addiction Medicine will offer a new track with topics that include alcohol use disorder, buprenorphine and the treatment of opioid abuse, and the medical aspects of marijuana use. All of these are in addition to the new course topics that are offered by our returning participating organizations, including the American Academy of Pain Medicine, the National Association of Drug Diversion Investigators, and the American Society of Pain Educators. Nowhere else in the country at any professional meeting devoted to pain has this many organizations from this much diversity of practitioners and experts working together to address all of the different aspects of one problem, pain. Our special interest sessions are always popular forums for the investigation of new issues in chronic pain, and among the 30-plus offerings in the track this year, you'll find new courses on managing abuse and diversion, pain and sleep disorders, the role of stem cell therapy, and an update on what you need to know about medical cannabinoids. Make sure not to miss the Fuden versus Gooden, the gloves come off. The two Jeffs will discuss the pros and cons of abuse deterrent formulations, urine drug testing, and the use of naloxone. And finally, with respect to this week's agenda, don't forget to take out your conference passport and check out the exhibit hall, which opens this evening and will remain open tomorrow and Friday during the scientific poster session, the reception tomorrow as well, and the poster podium presentations on Friday. Global Education Group is the accredited provider for PAINWeek, and we would like to thank Stephen Lewis, Brandy Lewis, Amanda Yamjorovich, Amanda Glazer, and Andrea Funk for doing a superb job on managing all the content development for this conference. Give them a round of applause. As you can imagine, walking around here and thinking about this venue and the number of attendees and the number of speakers and the number of rooms and the artwork that you see directing you to the various topics, It really does take a tremendous effort to bring a conference like this together. It also can't be done without the support of the health sciences industry. And we'd like to thank all of the commercial sponsors, especially our diamond sponsor, Teva Pharmaceuticals, our platinum sponsor, AstraZeneca, and our gold sponsors, Kaleo and eLab Solutions. Our media partners provide an enormous amount of support and visibility, helping to extend our reach in education about this conference and its topics. Key among them has been the participation of Haymarket Media, Postgraduate Medication, and PAINEDU.org. In addition to promoting awareness of PAINWeek to their multidisciplinary members, PAINEDU has sought out committed and deserving practitioners from across the country and have awarded 10 scholarships to this conference. I'd like you to join me in welcoming now PAINEDU's Medical Director, Kevin Zakharoff, to introduce those scholarships.
Thank you, Dr. Clark. And it always gives me great pleasure for this part of the keynote because I get to speak words that aren't mine. So what I've done is I've compiled segments of the different essays that we've received, and I'm going to read them to you now. Don't ask what the world needs. Ask what makes you come alive and go do it. Because what the world needs is more people who have come alive. That's a quote from Howard Thurman. This concept has been the driving force in my life. It is not my life or my pain. It is not my challenge or success. It is never my role to dictate the direction my client will go. However, I will be there to accompany them on their journey until they are ready to go it alone. We think we know the treatment of acute pain, but we still disappoint ourselves, our patients, and their families. As for chronic pain, we're in our infancy. We ignore the literature that continues to show that we are not educated enough, that only 25% of physicians who prescribe opioids are confident in their ability to safely manage their patients, and that the public counts on us to help manage their pain, but also keep them safe. Imagine the expectations when they place their children in our care for pain management. The subject of pain is so broad. How does a pain educator in a hospital condense such a huge and somewhat daunting topic into an hour-long useful presentation for the various hospital disciplines? On top of this conundrum is the fact that nurses benefit from continuing education that has a different emphasis on pain management than physicians do. Pharmacists, physical occupational therapists, and other medical disciplines all view pain and its management from still other angles. These differences require an educator to make presentations that vary in focus so as to be a benefit to them all. There is no education or training provided in my institution for pharmacists. Development of any clinical pharmacy services is from self-initiation, identification, and development. I would like to enhance my role and be an active participant in the care of these patients, and to do so, I need to have a better understanding of behavioral, social aspects of patients who are on pain medication, understand the differences between addiction and dependence, how to determine the clinical indication for pain medications, how to know the depth of pharmacology of pain medications, how to select one opioid or the other, figure out equal analgesic dosing, drug interactions, adverse effects, and understand the reporting of qualitative and quantitative drug screening, and how to use assessment tools to better access pain control and detect aberrant behaviors. I feel that my unique experiences, leadership, and passion have solidified my dedication to succeed by continuing the Navy's traditions of honor, courage, and commitment to my patients and profession. My training introduced me to pain management. My injury taught me how powerful empathy can be, and how my experiences continue to motivate me. I have learned that science alone does not heal. Indeed, a good clinician needs steadfast compassion, keen listening skills, dedication, ability to fairly and accurately assess opioid use, and patience for lifelong teaching and learning. My newfound motivation for quality patient care has humbled me and taught me to be more understanding and empathetic towards my patient. As a pharmacist, my knowledge of medications is quite expansive. I know the effects, the mechanisms, and the side effects, but I am not as clear, however, as to how some of these medications may fit into a long-term, ongoing treatment plan for patients experiencing chronic pain. This will be my challenge. These are your words. Thank you for them. And now it gives me great pleasure to call attention to the scholarship recipients for this year. If you're here, please stand so we can acknowledge you. Christine F. Byrer, Marion L. Catalano, Amanda R. Comstock, Chris Fant, Wakita Grease or Griechi, Deborah J. Cusdow, David Leeson, Loanne Nui, Kathy Ann Sheehy, and lastly, our grand prize winner, who would like to come up to the stage, Dr. Tien Pham. Are you here? It's my pleasure to present this to you. Congratulations.
Thank you, sir.
You're welcome.
Well, thank you, Kevin. That's a wonderful representation and a selection of people that are carrying on great work. Every year, Pain Week and the American Society of Pain Educators like to recognize a few individuals who have contributed in substantial measure to frontline pain education. This year, we'd like to congratulate Dr. Kelvin Burton as the Primary Care Practitioner of the Year, Dr. Tanya Uritsky as the Pain and Palliative Care Practitioner of the Year, and finally, the American Society of Pain Educators has chosen Paul Galino, founder and president of the United States Pain Foundation, as our Pain Educator of the Year. We offer our thanks and congratulations to all of them. Please. So if you were with us last year, and for many, Pain Week has become indeed an annual event, you may remember our sharing and discussion of this unfortunate scene, this sign that was taken by one of our staff in the waiting room of a primary care practitioner. The general consensus was that this situation, surely not unique in the world of primary care, reflects a fear of the unknown and clearly an urgent need for more and better pain education. And clearly there is a lot to learn. There's always a lot to learn, and there's always things that we don't know, but yet that shouldn't deter us from trying to take care of people and combat the problems. As my colleague Steve Pasek observed last year, we've come out of the decade of pain with an appreciation for the naivete of both the polar positions on opioid therapy for chronic non-cancer pain. Pain medications are neither a panacea nor a pariah, and experienced prescribers understand the need for a nuanced and tailored approach to pain management for each individual patient. Skill and risk assessment, monitoring and documentation, and understanding of the psychosocial contributors to pain, the familiarity with alternative and adjuvant modalities, getting your patients invested in the success of their treatment, working with them to achieve common goals, taking into consideration their age, their gender, their ethnicities, all that vary across different pain conditions and their treatments. All of these are the elements that go into an individualized, patient-focused approach that people with chronic pain need and deserve. No one says this is an easy job. Given the time and resource constraints of our medical practices, it clearly is a challenge. And the complexity of the task is only compounded by a changing legal and regulatory environment in which states are starting to take matters into their own hands, crafting their own responses to the epidemic of opioid and now heroin addiction. But as Kevin has said in the past, and you'll see again shortly, pain patients are on the doorstep of every practitioner on Main Street. And so it's incumbent on every one of us to prepare for them and to take care of them in ways that make sense and that are within our scope of practices and within our expertise that hopefully will grow with every patient experience. We all have to make sure that Michael Brennan's prediction doesn't come true, that we all have a role to play and that we all have an opportunity to be effective in teaching not only our patients how they can recover and move forward from chronic pain, but also every one of our colleagues. And it's a little bit like walking down the hallway of your hospital and seeing trash on the floor. Do you stop and pick it up? Or do you walk by it and think, that's not my job? Because you're going to be surrounded by opportunities where you hear somebody else make a disparaging comment about a pain patient, about the treatments, about the hopelessness of it, about the difficult patient. And you're going to have the opportunity to say, wait a second, I take care of those patients and I get them better. And they deserve that. And you should be helping me to do that kind of work. So I would encourage you to look for those opportunities and to seize them. Now, before I turn over the podium to our keynote speaker, Charlie Argoff, I've known Charlie for a tremendously long period of time. And for those of you who have had the privilege of knowing him and working with him, he truly is an encyclopedic guy. Somebody earlier made that comment about his knowledge base. And he's also involved in a tremendous number of different projects. I mean, he is the consummate multitasker and successful in all endeavors. And when you're working with him from a distance, it's a little bit like being a storm chaser in Tornado Alley. You're kind of standing around wondering, is he going to show up? Is he going to be here? What's he going to do this time? And then you see him on the horizon coming in. It's impressive. And all of a sudden, whoosh, you're caught up in the chaos of this tornado. He does these amazing things, and then poof, he's gone. And you're left standing there saying, wow, that was fantastic. But you don't necessarily want to be carried off in the storm. So you tend to try to keep your distance a little bit. And because you want to witness the miracle, but you don't necessarily want to be a part of it. And so I was at a meeting one time, and I don't know if you remember this. It was in Boston.
I'm not talking to you anymore.
That's what I figured. And Charlie was getting ready to leave, and I was getting ready to leave. And he looks at me and he says, you want to share a cab to the airport? And I was like, oh, okay. And so we got in the cab together, and the cab driver said, you know, which airlines and which terminal, and Charlie said his airline, and darn it, it was First. So I said, yeah, I'm on the back end of Boston Logan. So we drive up there, and I'm one of these guys that likes to be there a couple hours in advance, have a leisurely walk through security, maybe get something to eat or read. You know, Charlie is. So we pull up to Charlie's terminal, and he says, hey, it's great to see you. Wonderful project. See you next time. Thanks so much. And I'm thinking to myself, it's okay. I'm okay. I'm here. Gets out of the car, he disappears. I said to the guy, I'm not getting out here. We can go on. No response. Just sits there. I said, I'm sorry. We can go now. He looks back at me and says, car no go. I said, what? And he gets out of the car, throws open the hood. He's up there for a few minutes, comes back. I said, what's happening? He says, car no go. And he just sits down. Doesn't say anything else. So I'm thinking, damn it, Charlie. So
You got serious problems.
I get out of the car, I go running through the terminal, try to find the shuttle bus, run through the airport, make it to my flight, cursing him all the way and thinking, holy cow, that's just what I thought was going to happen. Fast forward to last year, Deborah calls me up. She says, would you like to do Pain at Sea? It's a new thing that we're thinking about doing. It's this creative idea I've got, and we think this is going to be a really fantastic thing. Never been on a cruise before. Never really wanted to go on a cruise before. And I said, great, sounds like a wonderful idea. Who else is going? Charlie. But it was a wonderful time. We had a great experience, and I live to tell about it and introduce him to you tonight, because what he's going to talk to you about... They
already hate me.
Yeah, exactly. Are the harsh realities of being a highly trained and really a highly respected pain expert. And he's committed to both the patient and their care and the education that we've been talking about tonight. But at the same time, he's dreamed of owning a deli in rural Vermont. And thankfully for all of us, he's decided to defer that for the time being, but he's going to come up tonight and tell us about some of his reasons for making that choice. And so please join me in welcoming Charlie Argoff.
Okay, so thank you all for being here. So some of you stole some of my talk already because I was going to tell you how this came to be. We were having dinner. It was really a great experience doing PAINWeek at Sea for a lot of reasons. And another really great reason is that Doug Rollet was also one of the faculty members, and seeing people and their families, you have a great family, great wife, children, and sharing other experiences really makes you come closer together with people you've been working with for years. And it was a really extraordinary experience. And I was having a really great dinner. It wasn't expensive. It was just a really moderately priced dinner. I happened to be on the top, like the 15th floor of a hotel overlooking Istanbul. And I was sitting next to Deborah Wiener, who's principal at Aventine and the director of programming for this conference, and other colleagues, his family, my family, Doug, and other people. And out of nowhere, Deborah asked me if I wasn't doing this, if I wasn't working in pain management, if I wasn't working in Istanbul at that time, what would I be doing? And so I then had the good fortune, or made the mistake, because I'm here now because of that, I think, depending upon how we'd like to look at it, to spill my guts out and to say that I really had a lifelong dream of opening up a deli. And I was born in Brooklyn. I grew up having tremendous respect for and awe for really good corned beef, pastrami, knishes, other delicacies you can only get in a good New York deli. I mean, it's just the way it is. I also wanted to open mine in Vermont. Turns out over my adult life, I spent a lot of time in Vermont and love it up there. I started Bernie Sanders, by the way, but he's also from Brooklyn. But I also love Brooklyn bagels. And in fact, during my honeymoon, almost 30 years ago, I'm still married, as my wife and I drove through Basel, Switzerland, we were on our way from Luxembourg to Italy, I turned to her and wondered out loud what the Basel bagel response would be. if we open up a bagel store, now she's in the medical world as well, and she didn't really, now she doesn't pay attention to me when she doesn't, but we're still there. So anyway, Deborah then reminded me, as we continued to discuss my deli interest, the implications of my no longer being involved in pain management, clinically or academically. And that's when it hit me. I think I said something like, the deli is going to have to wait. And these are vital times for pain management, And as Dickens said, these are the best of times and worst of times. And I need to stay. I need to stay in this for my own well-being. I need to know what's going on. I can't leave. So what exactly did I mean by that? So I'd like to share with you key reasons, the 10 top reasons why the deli will have to wait. Okay? Reason number 1, the current state of pain management in general. Pain has been said a number of times, so pain is the number 1 reason why a person seeks health care, the number 1 reason. In the recent IOM report, as well as even the more recent release of the National Pain Strategy, together outline in great detail the staggering numbers of people in the United States that experience chronic pain, 100 million people, as well, or that's adults, as well as a plan to address how we can optimally treat people currently, as well as improve upon such in the future. For those of you not familiar, the draft National Pain Strategy was released in April of 2015 with a 45-day public comment period that closed in May of 2015. And this document includes objectives and plans related to key areas of pain and pain care, including professional education and training, public education and communication, service delivery, reimbursements, prevention and care, attention to disparities in population research. We truly have, this is really important, we truly have only just begun in this growing but young field to really address pain management in a systematic and coordinated fashion. There are new scientific discoveries reported nearly daily, and new treatments, both medical and non-medical, newly available or in development now. So now is not the time to leave. Reason number 2, the public's perception of pain. Despite these huge numbers of patients in need of care, there is still a lifetime of work to be done in educating both the public and especially the media, healthcare professionals, training programs, and payers that chronic pain is real and should be taken seriously. The media has had a tragic field day focusing nearly solely on negative aspects of pain management without reporting sufficiently on the very positive and exciting progress being made in our field. I was recently interviewed by a reporter at the New York Times. I will not tell you her name. The interview was supposed to be focused on many aspects of pain management. Instead, it turned out that the reporter was only interested in one thing, and one thing only: opioid misuse and abuse, as if pain management was a synonym for opioid use. In other words, this was what defined to her pain management. More to follow about this in just a few moments. Well, I'm a reasonable person in general, so I figured that this same reporter would be interested in steps being taken by the federal, state, and local governments, as well as the pharmaceutical industry and law enforcement agencies to address opioid-related abuse and misuse issues. So I invited her to report upon these efforts and to assist in such reporting, to attend a public hearing at the FDA that addressed such efforts. So I'm sure you know what happened. You would not be surprised to learn that not only did she not report on the positive steps being taken to limit harm in one area of pain management at the FDA hearing, she also did not even attend the hearing. Pain is often ignored, misconstrued, and further steps must be taken to educate and engage the public. Reason number 3, there are just not enough pain management providers that are qualified. We need to address the gap in the United States among the number of people in pain who are in need of further evaluation and treatment, the number of pain specialists, and the number of primary care providers who are also involved in the care of persons in pain. So the IOM report suggests there are 100 million adults in the United States who experience chronic pain, yet there are only 4,000 or so pain specialists in the United States. At the same time, there are over 400,000 primary care specialists if you include internists, family practice, pediatricians, OBGYN, and geriatricians. The results of a recent survey, which was done by mail, of 3,000 primary care providers, pain specialists, chiropractors, and acupuncturists suggested that 52% of chronic pain patients are primarily treated by a PCP, 2% by a pain specialist, 40% by a chiropractor, and 7% by an acupuncturist. The results of this survey also suggested that certain medical therapies, such as long-acting opioids, anticonvulsants, or antidepressants for pain reduction, were prescribed much more frequently, almost double the frequency, by pain specialists compared to PCPs. Both PCPs and pain specialists reported prescribing opioids less often now due to concerns regarding regulatory oversight. And this survey was published and completed before hydrocodone was rescheduled. Okay? Also of interest in this survey was that many PCPs did not feel comfortable in their ability to manage musculoskeletal pain and neuropathic pain. But at the same time, we're also not likely to favor mandatory pain education for PCPs. What was not analyzed was the effect that these behaviors and responses had on patient care, that these practices resulted in, and what was the effect on patient care, and that these practices resulted in. And so our system needs to be designed so that the needs of people experiencing chronic pain are matched to and addressed by the appropriate practitioner. This also means addressing the mismatch that may occur if any one of us as a person in pain wound up in the office of a provider saying that they're a pain specialist who may not offer the treatment that would be considered optimal for that person's needs, and saying you need to go to this person to get that care. Pain management is a medical specialty that spans multiple conditions as well as multiple treatment approaches. Having the skill set and wisdom to offer the person in pain what is best for that person is key to success. We would not expect a single provider, and please chime in if you think otherwise, to be able to provide every type of cardiac care to a person with a cardiovascular disorder. Why would we expect anything different in pain management? Reason number 4. Optimal pain management is not molecule-based or procedure-based, but most often requires a multidisciplinary effort. People in pain benefit most when their pain is assessed and addressed in a multidisciplinary integrated fashion. This approach must be embraced by those providing undergraduate or graduate level healthcare provider education, those paying for healthcare, those reporting about healthcare, as well as those receiving healthcare. How can we rest, or how can I open the deli while signs are being placed outside healthcare providers' offices stating that chronic pain patients are not welcome there? Or, this is totally true and tragic or horrifying, I learned this past Sunday before coming out here, from my nephew, who's in his last year of an orthopedic residency at a major medical school in the Northeast, that he has had no training in pain management, and that his attendings feel that unless a person is going to be operated on, that person is not worth seeing, and that all people in pain are drug-seeking at some level. Chronic pain does not exist as a vacuum or in a vacuum, and the broader medical community needs to become engaged. Reason number 5, lifelong education. I hope that we would agree that medical education is not only important, but how we are educated and what we are educated about has lasting influences throughout our professional careers. If your professional education does not include sufficient training in pain management, how can you possibly effectively manage the pain of the people who have entrusted their lives to you? Including assuming that you have the ability to evaluate and treat. They're assuming that you have the ability to evaluate and treat their acute and chronic pain complaints. Currently, far less than 50% of the over 170 accredited U.S. medical schools or osteopathic schools require students to complete a pain management course as part of undergraduate medical education. Furthermore, for those of you who have completed any residency training, how much pain management training have you formally received? How can we possibly be prepared to optimally evaluate our patients who are experiencing acute and chronic pain unless we receive such training, given the sheer numbers of people who experience pain? Such training needs to be mandatory and uniform at multiple levels and across all healthcare providers. Progress is being made, but not quickly enough, certainly not at a rate that will sufficiently help the millions of people who we treat with chronic pain. One consequence of this is the demonization of the person in pain. We are human beings, and we as human beings simply often do not react well to situations in which we feel ill-prepared. With so many healthcare providers ill-prepared to appropriately and comprehensively assess and treat people with chronic pain, the person in pain becomes the problem to those providers. A seemingly unconscionable outcome, but one that happens multiple times daily. What about the providers who are being attacked, seemingly merely because he or she sees people in pain? We need more education on pain management. Reason number 6, where will you be treated if you need pain management? At Albany Medical Center, we received the following referral letter from a PCP practicing just south of Albany. Quote, DR has been under my care for many years and has been on many regimens for management of her chronic post-cervical fusion pain, including opioids and adjuncts. Currently, my colleagues and I are in the process of discontinuing prescribing opioids in patients under 65 without cancer. The lack of consensus in the profession about the efficacy of opioids in chronic non-cancer pain makes it difficult to justify use of opioids in primary care practice. This is the best part. Having said that, still a quote from the referral, I think DR has done so much better on opioids than without them. This is true. I have it in my bag. I can show it. Like the development of a perfect storm, as already seen at the beginning of this session in the video, as non-pain management providers refuse to treat pain, as pain specialists agree to treat patients only with certain but not all possibly effective and relevant therapies, too many people in pain are lost and have no one to care for them. What would I do if I couldn't find someone to treat my pain? Reason number 7, are your patients satisfied? The new approach to measuring patient satisfaction. You may not know this. CMS, Center for Medicare Services, is now using new measures of patient satisfaction that may significantly impact pain management. Historically, there have been many approaches to measuring patient satisfaction, as I'm sure we all are aware. Now, per new CMS measures, when patients are surveyed about their satisfaction with their care and other measures, they're asked to rate these on a 0 to 10 scale. The number reported by CMS, just get this, is the percent of respondents who answer 9 or 10. This has to be 80% or above for an institution or an individual provider to pass. 80% have to be 9 or 10. The mean score has no meaning, and any score less than 9 is unfavorable, 0 being as bad as 8. This principle applies to many measures used by CMS for addressing patient satisfaction. So all responses less than 9 are equally bad. Patients don't know this when they're handed these surveys or sent these surveys, and per CMS guidelines, providers are not allowed to coach patients regarding the scoring system, nor provide them with a practice questionnaire. This scheme may have profound implication as reimbursement is tied to these scores and other measures, and it is mathematically impossible for every provider and every hospital or other relevant facility to win. Reason number 8, the need to teach evidence-based medicine as it was defined. Okay? How many of you believe in evidence-based medicine? Okay. What exactly is it, and what isn't it? So in 1996, in the British Medical Journal, the father of evidence-based medicine, it happened to be a gentleman, David Sackett, and several international colleagues wrote an editorial outlining what evidence-based medicine is and what it's not, defining evidence-based medicine as, quote, it's about integrating individual clinical expertise and the best external evidence. It was described as the conscientious, explicit, and judicious use of current best evidence in making decisions about the care of individual patients. The practice of evidence-based medicine means integrating individual clinical expertise with the best available evidence from systematic research. By individual clinical expertise, we mean the proficiency and judgment, is that blowing your mind, of the individual clinicians as they acquire such through their clinical experience and clinical practice. That is certainly not the way in which so-called evidence-based guidelines are used. Many clinical guidelines used in clinical care of themselves derive not from patient care experiences in any way, but solely as literature review analyzed with levels of evidence and recommendations made from such. Such reviews, and therefore the guidance that would come from such, leaves out most of the patients I take care of. right? Perhaps yours too, because many of the people I take care of, let's say somebody with postherpetic neuralgia who also has 3 other pain problems and medical comorbidities that would have been excluded by any study, or diabetic neuropathy or other conditions like that, would have disqualified them from the very particular studies that the guidelines used in determining their guidelines for the care that they're recommending. Am I the only one here today who sees the lack of logic there? In addition, sometimes, and this is, I mean, like, can you believe this too? Sometimes published guidelines conveniently don't tell the truth, leaving out data. Can you believe that? In 2014, the American Academy of Neurology, yes, I'm a neurologist, published a position paper regarding chronic opioid therapy for chronic non-cancer pain. 2 points. First, this position paper of the American Academy of Neurology was authored by a total of 1 person. Second, contrary to the statement made in the position paper that, quote, there is no substantial evidence for maintenance of pain relief over longer periods of time other than 3 months, 12 weeks. 12 weeks. There are actually multiple published studies demonstrating the long-term, up to a year or longer, there's a 3-year study as well, of opioid analgesics. How did this happen? It would appear that this supposed evidence-based guideline did not follow evidence-based medicine principles. Okay, reason number 9. Does anyone besides me see that there's an inherent conflict of interest that must be addressed? Okay, what do I mean by that? There's an inherent conflict of interest when the virtues of a company are on a level playing field with what is best for the patient. Let me say that again. There's an inherent conflict of interest when the virtues of a company are on level playing field with what is best for the patient. Within the past year, we received notice from one of the largest U.S. healthcare insurers in our own practice stating that the use of onabotulinum toxin A, please forgive me if I use the term Botox, for chronic migraine is considered experimental. Just for those of you who don't know, it's been FDA approved since October of 2010 for this condition. So this is experimental. And that per this company's, one of the largest in the country's, written policy regarding such use of such agents for chronic migraine, a person had to first fail to respond adequately to 60 days of treatment with 3 separate oral prophylactic medications, with several listed by that company in this policy that anyone can look at, that are not currently FDA approved for migraine treatment. Yes, they rejected our request as experimental, and here's how we responded. Quote, Botox is the only FDA approved treatment for chronic migraine. There is no requirement in the prescribing information for Botox that goes along with it for chronic migraine for a person with a diagnosis of chronic migraine to first fail multiple trials of oral medications before being treated with or being considered an appropriate candidate for Botox for this condition. Furthermore, there is no specific requirement from the FDA for Botox to be used for chronic migraine only after the person with chronic migraine has failed multiple trials of oral medications. The steps and medications that are suggested in your onabotulinum toxin A policy in 2014 as being required to be taken include demonstrated treatment failure of 3 oral medications for 60 days each prior to your coverage of onabotulinum toxin A for chronic migraine. And many of these treatments are not FDA approved for chronic migraine, and in fact none of them are FDA approved for chronic migraine, nor are they required per the prescribing information for Botox for chronic migraine. I hope you like this. We then wrote, ironically, it is your policy that is recommending off-label experimental uses of those oral medications for chronic migraine as they are not FDA approved for chronic migraine. So we won the battle. We'll see if we use the war, because they're not good. What? What was that? What was that? I don't think I can get censured for that. This is just one example in a sea of instances. Many of the largest health insurance companies are in fact publicly traded companies. So for a publicly traded company, the law requires corporate directors and managers to pursue long-term sustainable shareholder wealth maximization in preference to the interest of other stakeholders or society at large. The leading statement of the law's view on corporate social responsibility goes back to 1919 in Dodge versus Ford Motor Company, a decision that held that a business corporation is organized and carried on primarily for the profit of the stockholders. That case, in which Henry Ford was challenged by shareholders when he tried to reduce car prices at their expense, also established that it is not within the lawful powers of a board of directors to shape and conduct the affairs of a corporation for the primary purpose of benefiting others. This remains the law today. A 2010 decision, for example, eBay Domestic Holdings versus Newmark, held that corporate directors are bound by fiduciary duties and standards which include acting to promote the value of the corporation for the benefits of its stockholders. How then can such companies' actions be considered as in the best interest of the person who we are trying to treat? It is time for us to look at the elephant in the room and take a stand against corporations delegating how we should treat our patients. Reason number 10, remembering why we chose to become healthcare providers. As Sir William Osler, the father of modern medicine, said, 2 quotes, "It is much more important to know what sort of a patient has a disease than what sort of a disease a patient has." Second quote, "The good physician treats the disease. The great physician treats the patient who has the disease." I don't think I'm alone in considering other options and activities at some point in my life after a challenging and rewarding career in pain management. I hope that you will all continue to be active in pain management, embracing the multidisciplinary opportunities that we have in pain management to be great healthcare providers, treating the person who is experiencing the pain. We are here at PAINWeek, the largest pain conference held in the United States, to listen to learn from a faculty with various backgrounds regarding a wide range of pain management topics, to speak and interact with each other, to debate and argue with each other, to learn from each other, all in the name of improving the care that we can offer to the people who we take care of. There's so much more that we can do to accomplish better care, more at all levels. The deli will just have to wait. Thank you very much.
Good job. See what I mean? He's fantastic. Charlie, I hope the deli stays closed for a long time because we really need you. I do just have a few final housekeeping notes, and then I'll let you out of here. To help you navigate your way around PAINWeek, your first source for useful and valuable information is the mobile site accessed at m.painweek.org. Questions can also be directed to the PAINWeek staff, who you'll find sprinkled around the conference area and at the registration desk. In keeping with our green commitment, PDFs of the slide presentations and the course evaluations are only available through the mobile site. The online evaluation system will be available until October 9th, but we encourage you to complete your evaluations as soon as you receive a link to do so. Also remember to check the electronic meter boards near the main registration desk on this level, level 4, for any updates or changes in the course schedule. I want to thank you for all being a part of the largest and most ambitious PAINWeek conference ever. Please join us now for our welcome reception in the exhibit hall next door and get to know all the other healthcare professionals and supporting organizations who are dedicated to the betterment of pain education and practice. Thanks very much. Have a wonderful conference.